On behalf of the 4 course directors, Bernie Park, Dennis Weigel, and Eric Tolosa, I really want to welcome all of you to this first forum symposium on robotic thoracic surgery. I don't know if you guys know or not, but there have been previous iterations of this course in different fields, in urology and gynecology, the so-called PreArm meetings. These were joint endeavors between 3 major cancer centers, Mayo Clinic, MD Anderson, and Memorial Sloan Kettering, of course. And these were very instrumental, I think, about 10, 15 years ago in getting those specialties off the ground in terms of generating interest in robotic surgery. So with the significant experience of Moffitt Cancer Center, we thought, well, why not make a 4M course? And so this is the first time that we're really trying to bring those 4 cancer centers together and put together a course specifically devoted to robotic surgery in the thorax. So I really want to welcome all of you to Houston. The goal of this course was really to bring together the top experts in the fields in thoracic surgery today, the top thought leaders, and to have them come together to show us how they do thoracic robotic surgery. So we have some of the top people in the world. We're going to have some real pioneers in thoracic surgery and robotic, like Bernie Park. Foley is going to be here, Mark Deluski. And then for esophagus, of course, we have Rishi Reddy, and Kemp Kernstein's going to be here, and Inderpal Sarkaria. So really some top-notch people. We're very happy to have international participation as well. We have an expert in segmentectomy from China, Hee-Ching Lee, and then from the Berlin group has probably got one of the biggest thymoma experiences in the world. Dr. Ismail is here from Berlin. So really a terrific group we've assembled, and I hope that you find the course useful. So the outline of the course, we broke it down into a 2-day course. We're going to break each day into kind of a didactic session in the morning. There's going to be 3 sessions, and then we're going to break for lunch. There will be a keynote speaker on each day. Dr. Foley is going to be speaking tomorrow. And we have Dr. Randall Wolf, who's one of the innovators in robotic surgery, going to speak today at lunchtime. So that lecture will be in here. We're then going to break and split into 2. About half of the people who registered are going to be doing the hands-on lab. Now that lab is off-site. There's a map included in your pamphlet, and it's online as well. But there will be a bus leaving from here at about 1:30 to bring us over to the laboratory space. For those of you who did not register for the lab, and particularly designed for people who already have the basic robotic skills, we have a masterclass session. And this is going to be an opportunity to really sort of interact with those experts in robotic surgery, to really get into the nitty-gritty about how they do their operations. It's going to be very informal, basically a show-and-tell video session, and we're going to cover lung, esophagus, and mediastinal resections. I want to, first of all, thank our sponsors today, Intuitive Surgical, who are basically funding most of this endeavor, and without them we could not do any of this, so I really want to acknowledge their tremendous support. I also want to acknowledge the support of J&J, who also contributed, as well as our exhibitors, Wexler. I want to introduce 2 people, Dara Keener and Laura Guerrero. So these are my administrative assistants, and they have done a tremendous job organizing this. If you have any questions, ask them, find one of them, and they can help you. And then I also want to acknowledge our conference services, Eric Gagnon and Kelly Gilpin, who've just done a tremendous job organizing all of this. So some very brief housekeeping notes. As I said, there's going to be a bus leaving from outside of this building at about 1:30 to take people for the hands-on course over to the Memorial Hermann Lab. You should have received some CME paperwork in your brochure, so fill that out. To get CME credits, you have to hand that in to our conference services people before the end of tomorrow, okay? And then I want to remind everybody that there's a reception this evening. It's going to be, what time is it going to be at? I think it's at 5:30. 5 o'clock. So right after the lodge, we're going to have a reception in a restaurant called Third Coast, which is literally down the steps, across the breezeway, and then up to the top floor of the adjacent building. It's a nice place. So some of you may have heard that we had a little calls for celebration yesterday evening. So after the storms and Harvey and flooding and everything, we're really happy that the Astros won. And you're going to see a lot of videos today, but perhaps the most important one is this. So for anybody who missed it, this is Morton's winning pitch. So on that positive note, we'll get started. Okay, so our first speaker today is Joe Brown. I've known Joe for, 12 years now. Joe originally was a nurse in the Coast Guard for about 6 years, I think, before coming to MD Anderson about 12 years ago. And he is one of our most gifted and talented OR nurses and has a particular interest in robotic surgery and has really done tremendous things about trying to streamline the processes within the operating room. So Joe, I'll hand it over to you.
Thank you, Dr. Rice. Good morning, everyone. My name is Joseph Brown. I'm a registered nurse, clinical nurse in the operating room. Like Dr. Rice said, I've been here close to 12 years now. And on behalf of our nursing staff, clinical nurses, our scrub technicians, our equipment techs, our neuro techs, and our preoperative nursing assistants, I'd like to welcome you guys to MD Anderson. And also would like to say that I am honored to be standing here to present to you a nursing perspective on robotic assisted thoracic surgery. So let's go ahead and get started. The content of my presentation will be the following. We're going to talk about the robotic team composition here at MD Anderson. Secondly, we're going to go over the review robotic room configuration and patient positioning. Also, we're going to be reviewing helpful hints for emergency situations in which we don't really want to get into, but just in case we do, we want to talk about those things that we need to get done in order to handle those situations, and efficiency room turnovers. Now, let's look at our robotic team composition. Stephen Jobs, founder of Apple Computer, once said, "Great things in business are never done by one person. They're done by a team of people." And here at MD Anderson, we do believe that in our thoracic team. We believe in team. Now let's look at our robotic team. Our thoracic team, for any robotic case, consists of the following. We have a thoracic surgeon with also a thoracic fellow and resident. As you know, we're a teaching institution, so we have thoracic residents and fellows. We have a thoracic anesthesiologist and fellow. We have a Da Vinci circulating registered nurse. Also, we have a Da Vinci certified scrub technician. Also, we have a Da Vinci equipment technician. Their responsibility is basically, along with a registered nurse, to help troubleshooting any type of situation that comes along with the robotic and also other equipment that's within the room. And we also have our preoperative nursing assistant. And this is our team here at MD Anderson. Robotic room configuration and patient positioning using the operating room circulating zones. This is a standardized, systematic way of setting up an operating room used by nurses. At the end of the slides, you will see more information about this technique. The target areas today will be focused on are 3 areas. We're going to be looking at the lung, the thymus, and also we're going to be looking at the esophagus. The lung. Patient primary position is lateral decubitus. I had a patient volunteer. Actually, I made this up one day after work. This is patient A. It's shown to be in the left lateral decubitus position. Certain equipment that, as nurses, that we look at that we're definitely going to need is a bean bag, a gel pad. Also, we use here the Tremano 3D arm support. This is a click and move. As you can see on here, the Tremano basically holds the arm, and it's on a click and move, allowing the surgeon to manipulate the arm. We also, as nurses, look for the key bony prominences, such as the malleosis, in which you would see a heel pad, also the lateral and medial condyles, which the gel pad is covered. Also, we look at the greater trochanter, which is gel pad, and the brachial plexus. You can see we have a foam axillary roll, and the Tremano itself. Robotic XI room configuration, we're going to be looking at the lung, left and right, also thymectomy, and also the robotic Ivan Lewis esophagectomies. XI room configuration. Because of innovative technologies of the XI patient cart being able to rotate literally 180 degrees, positioning with this type of robot is not as difficult as the previous version of the SI. As nurses, when we're setting up the room and we have the XI robot, we are loving that day because there's not really much planning we have to do as far as patient positioning. So this is a very 2 thumbs up for the nursing staff when you guys post the XI robot. The XI patient cart comes into the patient perpendicular for the following surgeries: lung, bilateral, thymectomies, the anterior mediastinal approach, and for the robotic Ivan Lewis esophagectomies. That's it. So for staffing, for us to position the patient, it's so much easier compared to the SI. So let's go ahead and move on to the SI robot. We're going to go ahead and start with the SI robot, lung, right and left. Now, with the SI robot, the right lung tumor patient presents. The first thing we're going to do is basically the first surgical bed is going to be angled at 11 o'clock position. Why is this? This angle helps line up the SI robot boom instrument arms to be parallel to the intercostal space of the rib line. As you can see, where the ICS port, the intercostal space port, our surgeons normally place a single anterior and posterior port, and that's along a single rib line. What we want is the robotic boom arms to be parallel to that line. So this is the main reason why we turn our bed at 11 o'clock position. As you can also see, the robot is at the 12 o'clock position. For left pulmonary mass, we're going to kind of do just the opposite. The bed's going to be turned at a 1 o'clock position. And like I said, this helps align the robotic arms to be parallel to that intercostal space of that single rib line, and it allows those arms to be parallel to that. And also the robot's going to come in at a 12 o'clock position, as pictured here. Robotic SI configuration for thymectomies, and this is an anterior mediastinal approach. Now, key points for this, for thymectomies on the left side, this patient's going to be in a supine position. Now, once the patient's in a supine position, we're going to move that patient to the left side of the bed, as close to the edge as possible. The next thing we're going to do, we're going to place a long gel roll or a padded green sheet that's padded underneath the patient underside. And what this does is going to basically lift up the hemothorax. And this allows for better access for the robotic arms to go into the particular location. Next, the left arm is placed in that Tremano 3D retractor we talked about. It's going to be lowered down below the surgical plane of the bed. And this also helps with the positioning of the robotic arms. Then another operative tumor side arm, which would be the right arm, is going to be padded. You're going to include a hand roll, and then we're going to tuck that arm and secure it along the right side of the body. And as you can see, the patient cart is going to come in on the opposite side, which is the right side. Let's go over right thymectomy. Right thymectomy, same key points. The patient's going to be moved over to the right side, to the edge of the bed. We're going to place that large gel roll on the underside of the bed from the pelvic iliac crest up to the scapula. And this helps, like I said before, it's going to lift the hemothorax up, giving better access, robotic access. Next, we're going to place that right arm in that traumato retractor. We're going to lower it down with the click and move. We're going to lower it down below the line of the surgical bed line plane. And then the non-operative arm, which is the left side, is going to include a hand roll, and we're going to tuck and secure that along the body. And as you can see, the robotic patient cart is going to come in on the opposite side, perpendicular. Robotic Ivan Lewis esophagectomy. This is a two-step procedure that the surgeon does. Both arms are tucked at the side. And as you can see, the patient robotic cart is going to be coming in over the head. And for this particular procedure, we do use all four arms of the robot. The second part of this is a left lateral decubus position. We kind of covered this for our right thoracotomy. As you can see, the bed is going to be angled at that 11 o'clock position. The robotic patient cart is going to come in at 12 because you want the robotic arms to be parallel to the intercostal space where for the port placement along that single rib. Troubleshooting situations. Troubleshooting situations, we're going to go over first is a robotic XI stapler jam. Normally, you would see this on any type of lung tissue. Now, Intuitive have created a wrench Da Vinci emergency grip tool release. Here's a picture of it here in the center. And we keep ours in our vision cart within the operating room. It's pill packed and it's sterile. It's recommended by Intuitive that this grip release tool be kept in a single drawer in the vision cart. Just in case of an emergency where you cannot release that XI stapler, you don't want to be calling down for nursing staff to be having to wait for that to come up. So they recommend that you keep this in your vision cart in a single drawer, in which we have ours here. And it basically lives there. Now, the process on how to open the jaws of a robotic XI stapler is pretty difficult. And the directions are on our grip release tool. So let's go ahead and see if I can explain this to you. First thing I want to kind of point out is if you see number 2, you can see a little white covering over that. That's very important. So the first thing we're going to do is the surgeon's going to hit that emergency stop button. Secondly, your circulating nurse is going to open up that key pack onto the sterile field, and either your resident fellow or your surgical technician is going to go ahead and do this process. They're going to place their hand on the cartridge, and they're going to place that key into hole number 1, and they're going to turn that until slot number 2 is clear. Okay? So first goes into 1, they're going to turn it clockwise until slot number 2 is clear. Okay? Once that's done, they're going to remove the key, place it in slot number 2, and turn it 12 times until you reach a hard stop. This, like I said, this is a process. Once you do that, you reach that hard stop, you're going to go to slot number 3, okay? And you're going to turn it 1/4 turn clockwise. And what that does is going to basically open the jaws and release the tissue of that stapler. At that point, what we're going to do is the sterile personnel, they're going to remove that instrument, we're going to tag it, and your circulating nurse is basically going to do a report on that misfire of that stapler. So this is a really key element to have within the operating room for misfires for robotic surgeries. Robotic emergency undocking, converting to open cases. It's something that we do not ever want to see, but it's something that we have to be prepared for. So let's go over some of those techniques. During our pre-planning and also our pre-checklist here at MD Anderson, I'm sure you guys also would do this, we discuss those things that possibly could go wrong during a particular case. And we try to plan for those things to go wrong to make sure we have things available so we're prepared for something to go wrong. What I did was I broke this down into each particular team, and I kind of put out each particular segment what the teams are responsible for. For our surgeon and anesthesiology partners, they basically are the ones going to request an emergency undocking. Our surgeons will hold pressure, tamponade on a particular vessel, and release any other tissue that we need to remove those instrument arms and instruments from the robotic patient cart. The camera is also, normally it's maintained for visualization until you have an open thoracotomy, laparotomy, or a sternotomy. For us as registered nurses, what are we doing? We'll have one standby, open instruments on the table, ready to roll into the room in case an emergency happens. We'll have our chest instruments, our chest retractors, we'll have our Burford retractors, and our sternal saws all ready to go. We normally talk about having packed red blood cells ordered. Here, we always order at least a minimum of 2 units of PRBCs, have them in our satellite ready to go. We also have a thoracic mobile cart outside our room. Our thoracic mobile carts has staplers. It has everything that we need to facilitate any type of bleeding emergency. And one thing about here, we have about 32 rooms. Our robot is mobile. It goes from room to room. So our thoracic cart is able to move with our thoracic robot and able to, for the nurses, we don't have to run as far. So this is a very big benefit. And also, the nurse is going to assist with undocking the patient cart. Now, our certified scrub technician and our thoracic resident fellow, they kind of have the same task when it comes to removing the instruments. Our certified scrub technician, they will remove the designated instruments or endoscope once the surgeon has released the tissue. Our surgeon normally tells us which arm to remove. Then they will disconnect the cannula from the instrument arm and move those designated arms out of the way for an open procedure. Once we have an open thoracotomy, they follow the same steps for the other 2 arms. And our thoracic fellow do the same as our certified scrub technician, but what they do is they also prepare for and they help with the open procedure. Ways to control minor bleeding during a lung case. We use a dental roll with a radiopaque indicator. This dental roll is placed through the robotic trocar and used by the surgeon to hold pressure on any small vessel. Also, it's used as a peanut for dissection of delicate tissue. And here's a picture of the one that we basically use. Another thing that we use here is an argyle suction catheter. Basically, this is a catheter that you can find from anesthesia that they use for suctioning out their ET tubes. What we do is we remove the chimney valve, which is here, off the suction tip. We connect it to the Da Vinci suction. And normally on this end, we'll have a striker suction irrigator. We will put this part inside the robotic trocar, and the surgeon is able to actually manipulate that suction to precise areas within the chest. Robotic room turnovers. Room turnover efficiency. This process compared to the main OR turnovers have decreased our overall time by at least 11 minutes. And if you were to sit for 11 minutes, that's pretty much a long time. So what I did was, again, I broke it down into each particular team. Our anesthesia partners, they basically will see our patients early. They will have some key items pulled and ready for the next case. Our Da Vinci registered nurses, one thing I always want to say is, I tell our nurses, is clean as you go. Because if the case is clean at the beginning, just as clean as at the end, the room turnover is going to be way much faster. So once the case starts, something that we started doing is we call for the case cart, our next case cart early. Once all our nursing charting is complete, we call for our next case cart. We basically pull for our scrub technicians. We have our instruments, supplies, sutures, all pulled and ready to go. So our scrub technician does not have to pull anything. It's ready to go. This is part of planning. This is part of preparation. Also, something as simple as setting up an empty cart, so that way when the scrub technician puts their dirty instruments on the cart, they don't have to, they can just place it on the cart and they're ready to go. Once the first count is complete, the closing count is complete, we normally break down as much as possible within the room. That's including the double ring stand. And our DVRNs, they assist with room turnovers and for opening. This is part of teamwork. Our certified scrub technicians, they make sure that the instruments are strung up and ready for the pan. Trash is literally placed on a dirty cart and taken away by our DVST. And by the time they come back to the room, our rooms are already turned over. Our perioperative nursing assistants, they help gather the supplies prior to the case being ended. And as soon as that patient is moved over to the patient PACU bed, we start stripping the bed down, wiping everything down. So by the time, like I said, our scrub technician comes back, our rooms are pretty much done. We've done 13-minute turnovers here, which is a record. And one thing about that, you really have to have a leader within that turnover team, and you have to really motivate the team members around you to have them have that kind of turnover time. Great things in business is never done by one person. They're done by a team of people. I like to thank Lishra Swift for her help and support and her nursing staff here at MD Anderson. I also like to thank Georgie Viernes and Mark Ungabiller. I'd like to thank you for giving me the opportunity to speak to you today. Thank you.
Thanks a million, Joe. We're going to take questions at the end. We're going to have a panel discussion, so all of our speakers will be able to answer your questions at the end. But we're going to switch over to the next talk here, if I can pull it up. There we go. So it gives me great pleasure to welcome back to MD Anderson Nadine Turner. Nadine Turner is a nurse, currently the director, I think, of Preoperative Services and the Cardiac Cath Lab at CHI St. Luke's across the street, but was formerly our lead OR nurse, director of OR nursing here at MD Anderson. Nadine brings with her over 20 years of nursing experience and is really credited for starting the whole robotic team here at MD Anderson. So she was here right from the very inception, and when we began, I think our first robotic cases were something like 2006 or something. And she built a phenomenal team of nursing staff and scrub nurses and OR techs, which are so critically important. So Nadine's going to talk about how to do that and how to make a successful OR team. Thank you.
Good morning, ladies and gentlemen, and welcome again to the 4M Symposium on Robotic Thoracic Surgery. As Dr. Rice said, I'm Nadine Turner, and I would like to thank Dr. Rice and his esteemed colleagues and the University of Texas MD Anderson Cancer Center for affording me the opportunity to present to you today. The robotic program was started in 2006 and has grown to incorporate several service lines, including colorectal, genitourinary, gynecology, hepatobiliary, reconstructive plastics, and cardiothoracic surgery. The burgeoning successes of the robotic program has and continues to be a testimony to the robotic teams. We have been able to create. These teams are essential to patient care, clinical practice initiatives, and our overall program growth. Today, I will identify the measures necessary to build, successfully manage, and sustain robotic surgical teams. Robotic team development should always be centered around optimal patient care and should provide a platform that fosters the desire to be the safest surgical environment in the world. To accomplish this objective, each robotic program initiative must establish their robotic program development strategy. First, you should take inventory of your physical resources, your space, your staff, your systems, to better understand the roles and responsibilities required within a robotic program. The elements needed to form robo-teams should include thorough comprehension of required roles and how each role aligns to the program development and organizational objectives. For the purposes of meeting the presentation objectives today, I will identify how effective planning and implementation of a robotic team program model will facilitate patient care optimization. The focused assessment on team construction as it relates to optimization of robotic surgery practice interventions will be discussed for their value in driving a successful robotic program. Additionally, these program success measurements will be explored as a method of achieving positive robotic program outcomes. The impact of team science, the strategic planning for resource allocation, and the purposeful use of debriefing methodology will be discussed as a mechanism for achieving the best pathway to robotic program development and growth. Robotic team development requires an understanding of your people, their strengths, and areas of opportunity. To use a sports analogy, you must know and understand your starters, develop your bench, and emphasize how important each member is to the team in the achievement of stated goals. And if you still question Houston's ability to build successful teams, just ask the 2017 World Series champions. Emphasize the we. Explain what we are doing. Explain who's involved and why. Explain how we plan to develop and accomplish our patient care and administrative goals. Now that we've constructed the foundation for our team development, we need to turn our focus towards the elements for team success. The primary elements for team success includes skills, knowledge, and attitude. We can teach skill through training modules, vendor sessions, hands-on activity with robotic systems, surgical setup, robotic simulation, dry and wet runs. We can develop knowledge through fostered proficiency, advanced practice, and competency validation. Attitude, however, must be assessed for its positive or negative force on team harmony and development. Positive attitudes must be reinforced and supported to ensure that the elements for success continue to thrive among team members. How should you measure team success? Select a method for how you will assess your team's competency level and establish an acceptable minimum threshold. Assess safety protocols and emphasize this as the priority for the team. Develop or incorporate a stop-the-line philosophy such that any team member is empowered to halt the progression of a procedure when safety parameters are not being met. Always include the team. There's nothing too trivial when it comes to safety. Holding routine and impromptu debriefs supports the team and establishes a spirit of inclusiveness. Communication and comprehension are the best defenses against untoward events. Monitor expansion into new robotic uses or approaches. Establish parameters around the incorporation of new robotic approaches and establish expectations to optimize safety, efficiency, and growth. These collective measures detail a scientific approach to building and establishing successful robotic teams. So, what's the science behind team development? It involves a detailed assessment of the methods necessary to develop collaborative working groups in order to achieve desired patient and organizational outcomes. Teams must be structured around a guiding purpose and strategy to optimize team development. In the hallmarks of team science, it has been proven that the essentials of a team are not simply created by working in the same place. A team is formed once there is an alignment of the task and the individual or group's purpose. The first measure within the science of team building should be to define your team's purpose. You should ask questions that foster transparency in helping to define your team's purpose. For instance, is our purpose safe surgical practice? Is it efficient surgical throughput? Is it to become a center of excellence for robotic surgery? Or is it a collective of these examples? Whatever the purpose, it must be clearly defined and routinely measured for success. The second measure of team science should be to develop your team strategy. Consideration should be given to how these individuals will come together. How will they communicate? How will they manage the complexities of a robotic surgical program? There must be a continual review of benchmarks that define team function and reinforce transformational success. Work to ensure that each success is celebrated with acknowledgement and communication of goal achievement. Failures are to be thoroughly reviewed to assess the immediate need for improvement and to ensure optimal patient safety measures are in place. Failures are an excellent indicator of what has not worked, but the cost of failure is too high to risk. mitigate failures with thorough planning and preparation with and for the robotic team. Now that we've established the building blocks for successful robotic teams, and we have defined our purpose, as well as our chosen strategy, our defined functions will now chart a course towards success. But how are we to allocate our resources? First, we will want to make our program patient-centered, but we need to consider how we achieve all these initiatives so that we have a positive return on the robotic program investment. Robotic staffing ratios must be based on optimal care and safety. What has worked well for MD Anderson Cancer Center is a 4-team member approach for each robothoracic case: 2 nurses, a surgical technologist, and an equipment technician. This is a self-contained team. They can manage the complete care of the robotic surgical patient, provide efficient flow, and maintain a high level of safety through consistency in practice. There should be a consistent balance in competency and proficiency for the robotic teams. The surgical complexity demands it. Surgeons rightfully need and demand the same level of competence regardless of the time of day. So as administrators, it is our responsibility to form complete teams with parallel skill sets and efficiencies for optimal program success. Surgical volumes must be closely monitored for growth or decline to guide accurate projections for program development needs. Create open access opportunities within the robotic block schedule to facilitate program growth. Provide opportunities for managed simulation to increase training exposure and clinical proficiency with the use of robotic systems. Lastly, prepare to facilitate routine debriefing sessions. Information must flow freely amongst team members and be measured against achieving the defined functions and purpose of the team. Incorporating benchmarking and scorecards for robotic staff will provide suitable guides to assessing their individual team member function. These criteria can accurately illustrate effectiveness in optimizing robotic surgery practice. For example, an appropriate benchmark would be average turnover times for procedures between teams. This information would then be reflected on an individual scorecard to provide insight into their team's performance and their contribution to meeting the defined patient care expectations. Once the process of debriefing is established, administrators should prepare to ensure high reliability within the robotic program through containment of errors, optimization of care delivery systems, and consistent management of the robotic investment. We must work to evaluate successes and enhance sustainability and repeatability. Together, these essential keys have proven to be an effective strategy for building, implementing, and evaluating a robust robotic program. This concludes my presentation. Thank you.
All right, well, we'll move on now. Thank you, Nadine. That's fantastic. We'll move on now to a discussion a little bit about the other side of the ether screen here around the anesthesiology for robotic surgery, which is a little bit different than your regular thoracic cases, as you'll see. So it gives me great pleasure to introduce Dr. Gabriel Mena. Dr. Mena is a close colleague of mine, but more importantly, a close friend of mine. He did his undergraduate and medical training in Bogota in Colombia, and then came to the United States, where he did a residency in anesthesiology in, I think you finished in, 2005? So I remember meeting you when I was doing my residency there. So he's currently an associate professor of anesthesiology and a real leader in anesthesia for robotics, and especially for enhanced recovery. Gabe has really been central to pushing our enhanced recovery program forward. He's also the founder of a charitable foundation, United to Cure, which aims at providing surgical and anesthesia services to kids in underdeveloped countries. And in fact, we're lucky to have him today because at 4 o'clock he boards a flight to Colombia, where he's traveling with one of our heart surgeons from Methodist to do an organ transplant on a poor girl in Colombia, I believe, who has a cardiac tumor. So we're glad that we can get you to give a talk here before you jet off.
Good morning. David, thank you for that kind introduction, and I want to take the opportunity to thank the organizing committee for putting together these tremendous program symposium with great academic content. Today I want to share with you some important anesthetic considerations during robotic-assisted thoracic surgery from the experience gained over the last 5 years, as these have become routine cases at our institution. The anesthetic management during this novel surgical technique can be complex and requires a thorough understanding of specific situations, such as the fact that this is a unique OR setting, patient positioning, fluid management, hemodynamic monitoring, and optimal lung isolation. After the inception of robotic surgery, we have really witnessed a paradigm shift in the practice of thoracic anesthesia at our institution, leading to the implementation of specific strategies, technologies, and techniques that are used during these cases. And I'll share with you in the next few minutes. Some of them are our ERAS pathways that have allowed us to accelerate patient functional recovery and improve patient outcomes. Specific regional blocks, such as the posterior intercostal block and the direct surgical vision, that allow us to minimize the administration of opioids in the intraoperative period and perioperatively. The use of video double lumen tubes in this type of surgery that allow us to continuously visualize the position of the tube in the trachea and in the carina throughout the surgery without the need of a fiberoptic bronchoscope. And new technologies that allow us to monitor hemodynamics, minimally invasive, being able to get away with not using arterial line catheters. This is an aerial view of our medical center, home of the 2017 World Series champions. And not different in size from our downtown that is very close, and where we currently have the largest congregation of Da Vinci robotic units in the world. We have 33 of them in our medical center and 4 at MD Anderson that are being used every day. And as you will learn and see throughout the meeting, it has really revolutionized management of these surgical patients undergoing procedure for lung cancer, improving their outcomes, and decreasing cardiopulmonary complications, bleeding, and so forth. One of the important aspects that I want to share with you is the fluid management, because in the United States and in the world, we have really very disorganized fluid management in these type of surgeries. And what happens is that most of the anesthetic management have been done through fixed fluid replacement regimens based on weight, depending on the patient, and etc. And you can see the study from Kim and co-workers, John Hopkins, in collaboration between the Department of Surgery and Anesthesia last year. They looked at the administration of crystalloids in over 6,000 patients. What they found was that there was tremendous variability depending on the surgeon, the anesthesiologist, the type of surgery, and the type of patient. This is very problematic because, as you can see in this slide here, and has been clearly elucidated in the literature, in the x-axis you see the volume status, y-axis you see the morbidity. As you move away from this perfect state of euvolemia, of no volemia, complications increase dramatically from under-administration of fluids such as acute kidney injury, cardiac ischemia, sepsis, and from over-administration of fluids such as leak of the anastomosis, pulmonary edema, congestive heart failure, etc. So how do we maintain our patients in the perfect state of homeostasis, accepting that the arterial blood pressure, CBP, urine output, heart rate are very insensitive parameters to let us know if a patient is going to respond or not to a fluid challenge? We have now, what we use at our institution is really a goal-directed approach, individualized to each patient and tailored to achieve specific physiologic parameters, more based on flow rather than pressure. We have non-invasive technology at our fingertips that we use for these robotic cases that give us continuous bit-to-bit information about important physiologic parameters, not only the systolic, diastolic, and mean arterial pressure, which is the data that you get from arterial line. It actually gives us more thorough information about cardiac function, cardiac output, stroke volume, and that allows us to infer the delivery of oxygen to the most important place, which I care personally, which is where you surgeons are operating. That's where we need to deliver the maximal oxygen to those tissues, and I think they have become very beneficial at our institution. And it also allows us to know exactly where is the patient positioned in the Frank-Starling curve, who's going to respond or not to a fluid challenge during thoracic surgery. I want to show you a closer view of these kind of devices we use routinely, and we are in this specific robotic-assisted thoracic surgery, minimizing the use of an arterial line catheter that is really not indicated for this type of procedures. Now, technologies do not impact outcomes. What really impact outcomes and decrease complications are using the appropriate algorithms, and we have used some validated use at our institution for the intraoperative period and for the post-op period, in which we manage hemodynamics and we standardize the fluid management in our practice. Our next step is to incorporate these algorithms that I'm happy to share with you into the software. So like an anesthesia machine can alarm when there's hypoxemia, it will alarm the anesthesiologist, CRNA, resident fellow about tailoring fluid management during thoracic surgery. This is going to be very important in the future. I want to switch gears now to lung isolation, because lung isolation for this type of surgery is paramount in order to achieve optimal surgical exposure. We have incorporated into our practice this video double lumen tube, or VivaSight. It has an integrated high-resolution camera at the end of the tracheal lumen, and it's connected to an LCD screen. So what this allows you is for continuous visualization of the position of the tube within the relation in the carina and the trachea, and you as surgeons and anesthesiologists, we can see this throughout the entire surgical procedure without the need of fiberoptic bronchoscope. As you can see here, this is very important, more so when we use the SI unit, when the head of the bed is away from the patient, as Joseph already showed you all very nicely with his diagrams. You know, it's really, there's a conflict between the robot and the anesthesiologist and the head of the bed, so this will really facilitate you as surgeons, your exposure during robotic surgery and not being interrupted. You know, it's difficult to get back there and get the fiberoptic bronchoscope and check positioning. And I want to show you a video, share how this is, I don't have a mouse. I guess I can. Okay. So there we go. And you'll see more and more. We use handheld videolaryngoscopes like this one, so the normal blades that you see in the OR, they will disappear for this type of cases. They allow for better exposure. We dry the secretion so that camera is not occluded with secretions. And I want to show you a couple of things, because this is the vocal cords, as you can see, and then I'll show you the LCD screen. There is the tube. And this is the LCD screen that comes there. Then you rotate that 90 degrees to the left, as you will see, and you will see the surgeons, everybody in the room can see the insertion of the tube, probably less traumatic. You're doing this under direct visualization, not blindly. You know, sometimes, as you all know, there's endobronchial tumors and there's lesions that you don't want to cause bleeding, so you'll see constantly the insertion of this tube. There we go. And you go to the left main stem, right there. And then I can, and I'll show you, I inflated the bronchial cuff for the final position. And that's all you have to do throughout the case. You'll see that continue without the need of the fiberoptic bronchoscope. These are the only studies done in the United States with this type of tube. Unfortunately, what they have focused on in their results is the time to achieve intubation, which is not really important to us, because the difference between 1 or 2 minutes, that's not really significant. Our group at MD Anderson, led by Dr. Singh, our group of thoracic anesthesiologists, Singh, Paraganan, and Jackson, did initially a retrospective study, and then now a prospective study that is in press. And what they were able to conclude, more importantly, that achieving rapid intubation is the capability of continuous visualization of this tube and not disconnecting the patient that leads to hypoxemia. And I'll show you a quick video of how this happens. You see this patient is connected constantly to the circuit. They have poor pulmonary reserve. What we usually used to see, and you can see while the patient is being placed in the right lateral decubitus, what's going on with the tube. Before, we used to disconnect these patients, and there's results with hypoxemia and desaturation in with patients with poor pulmonary reserve. And I want to finalize sharing with you a little bit of our ERAS initiative. As some of you have never heard about it, if you haven't, just wanted to share with you that what we want to do is really mitigate the inflammatory stress response of surgery. That is done by minimal invasive surgery, robotic surgery. We use opioid sparing techniques, multimodal analgesia, anti-inflammatories. We do change some of the surgical dogma. The chest tubes are removed much earlier, no Foley catheters, and the patients are really almost forced to walk on the first day and to eat the same day. So really, there's a lot of things that we're doing together in order to accelerate patients' functional recovery, patient satisfaction, and patient-reported outcomes. And why is it important at an oncologic institution to think about this? And this is a slide from Benton. As you can see, in the x-axis, the perioperative period, the y-axis, the risk of metastatic formation, and this perioperative period is when the patient is more vulnerable to micrometastasis. Some of the surgical stress that affects the immune system, as you all know, but from our side, the opioids and the volatile agents, the inhaled agents, have been really associated to a negative impact on the natural killer cells. And that's been shown in many types of cancers. This is a study from the University of Michigan looking at the relationship between the mu receptor and the promotion of opioid growth factor-induced proliferation, migration, and epithelial mesenchymal transition in human lung cancer. It seems that there's an overexpression of this receptor, and this has been shown also in prostate, colorectal, and ovarian cancer. Reason why we really focus on multimodal analgesia, which is basically using several pharmacologic agents with different mechanisms of action that work synergistically, with the whole goal to block the ascending and descending pain pathways to minimize narcotics in the perioperative period. We use, and probably Dr. Rice will show you this throughout the course this week, specific posterior intercostal block with long-acting local anesthetics. This is done by the surgeon under direct visualization with the thoracoscope. And this really allows, as you can see, the perfect distribution of these medications that go all the way to almost to the paravertebral space. And I can tell you that we're using the same amount of opioids that a GI doctor uses for a screening colonoscopy. For these cases, just really minimal opioids, almost nothing. But these blocks have to be perfectly placed. And what we've seen is obviously a tremendous reduction in the administration of opioids. Our patients, more than 50% of them go home after these thoracic cases without opioids. The whole goal is to get to 80 and probably one day to all our patients going. This is extremely important to us here at MD Anderson due to the current opioid epidemics and the opioid emergency that we're living in our country. And, to finalize, I see a bright future for robotic surgery because, as you all know, our healthcare system, the future is unknown. It's very fragile right now, where it's mainly fee-for-service, high volume, low quality. And I think that, as we in the future are able to move more to a comprehensive cost of care, funds of payment, implementing the ERAS pathways and combine this with the patient-reported outcomes, we should be able to demonstrate to the payers and to the stakeholders that the initial astronomical cost of a robot and the instruments, is really diluted once we're able to show that we have successfully decreased safely lengths of stay, complications or conversion to open surgery, complications, readmission, surgical site infection, as well as, we can help tackle these opioid epidemics. This is a study by the group of Mena and Cedars-Sinai Medical Center in minimal invasive thoracic surgery, and they were able to show us, as you can see, that as you decrease the length of stay from 7 days safely to 2 days, you obviously now can do 3 VATS in a week in the same bed, and then you triple the revenue to your institution. And that's going to be very important for your administrators to start looking at those numbers and understand the value of this technology and the future. And then to finalize, an image is more important than 1,000 words. This is one of our ERA's robotic patients. This patient underwent 48 hours before this picture a left lower robotic lobectomy, and he's on the bicycle, and it's really fascinating to see this, and we want to continue paving the way in the United States in this arena. We want to harness all available knowledge, disruptive technologies, and medications to continue improving outcomes in our surgical population at MD Anderson. Thank you.
Thanks, Gabriel. Good luck on your travels today. So we'll move on next with Dr. Bolton. Billy is a thoracic surgeon at Greenville Health Care Systems in Greenville, South Carolina. He's an associate professor there. And I wanted Billy to talk today because Billy started out doing his residency in the University of Mississippi, but then came to us for back in 2005, I think, 2006, 2007. We were not doing any robotics, so he did a year's fellowship with us at that point, but then moved to South Carolina to join a practice where they did a little bit of VATS, maybe not too much, but zero robotics. And he has built perhaps one of the largest robotic practices now in the southeast of this country, and has been able to get his older colleagues to get on board as well. So I wanted him to come and talk to us today a little bit about how he began his own robotic program and how he made it successful. So, Billy.
I'd like to I apologize about my voice. It's going in and out. But I would like to thank David and the rest of the committee for putting me on to talk today. All right, listening here. Okay. So whenever we talk about making the transition to robotics, there's several things to talk about. But the first thing, and to me, for this presentation, sort of sandwiched in all these other presentations, is why. Why am I going to go through the trouble of listening to my partners bitch and complain at me about why am I making the world more expensive and more painful for them? So how do I get started once I finally come around the idea of why? How do I do a plan to make that safely? And some of the talks you've already heard about are going to help with that. Once I get started, what are the steps I need to complete that transition? And how do I show other people, but also myself and my partners that this was successful? So how am I going to go about doing that? So as I told you before, my talk's really going to focus on the why mostly. But as you've already heard from one of the other speakers, the only reason we're doing all the things we do is to make patient outcomes better, right? And so we have to keep that in mind when we're going about figuring out how to do this. So one of the things is that length of stay, we all know now, is less with minimally invasive lobectomies than open lobectomies. And so not only is it something we know, but even my 10-year-old son wanted to help out with the presentation. So he went to Google and he looked it up, and right there you can see, even just on Google, my son now knows that it's less days with a minimally invasive technique. So everyone must know that since Google does. So if you look at studies about on this, one of the studies I participated in was with Adams et al., and we compared our early robotic data to the STS database. And when we did this, we found that robotics had a decreased length of stay and decreased complications compared to open that was statistically significant, but even against VATS, while it wasn't statistically significant, it was due to a power, I think, and so it had improvements on both. If you get to more modern data, and some of the speakers that you'll see here today, Dr. O et al., 2017, this year, shorter length of stay, less complications, decreased conversion rate when you look at robotics compared to VATS technique, and a decreased number of patients with the robotic technique go to a facility. So we work on frail people, some of them don't go straight home, less of that happens with the robotic technique. Sir Foley, another speaker you'll see here. They looked at a multi-center trial, 1,300 patients. This was really a trial looking at their long-term data, which was very good and favorable. I recommend you read it if you haven't. But again, their length of stay was 3 days, minimal morbidity and mortality, and that was a 90-day mortality rate for them. So if we admit that the length of stay is going to be less with a minimally invasive technique, then that's going to lead to other things. So we have decreased length of stay, we have decreased complications, and decreased readmissions, which then is going to lead to what your boss is going to like, which is going to help people be excited about your platform, which is the improved profit margin for the system. So Foley looked at a study in 2014 looked at this and found that they did have a profit margin with robotics, so you could do this with profits, and I won't go through the numbers, but it was a decent amount. Swanson et al., so this was a group of mostly VATS surgeons, you know Swanson, and so they looked at this and they compared it and said that it was more favorable for VATS. So if we're here at a robotics meeting, why am I bringing up that the finances were better from a VATS technique? Well, because I think that it doesn't really answer the whole question, and you'll see that here in a minute, and hopefully the next speaker will go a little bit more into that detail. But what I'd really like to focus on how we talk about finances is both of those studies there looked at the one time, that one hospitalization, and how much did I make for doing that lobectomy with that stay. Freeman looked at, in 2013, looked at it a different way. They looked at what were the variables that decreased our profitability, and one of the main variable was our length of stay. So getting our length of stay down caused less complications and less readmissions and improved our overall profit margin. So that leads us to, all right, well, why aren't we doing all these VATS if it's more profitable that way? Well, if we look at the rate of adoption for VATS lobectomies, it's not quite the same rate that laparoscopic cholecystectomy was. If you look back, 2006, McKenna looked at it, and it was about 5% people doing VATS lobectomies in the country. D'Amico, 4 years later, looked at it again. It was about 19%. And then you think, well, we must be way better now. That's the old data. We're way better than that now. Well, study in 2017, 21% VATS lobectomies. Now you're like, well, that doesn't make sense. I know I've seen data that's better than that. So this was a natural cancer database study. They looked at it. They saw 21% were VATS. And in that study period, they went from 3% to 9% robotic cases. If you look here, I said, well, I want to get some better data. So I went to the people who would be wanting to sell the robots, and I said, give me all the data you have to let me know what's going on. And so Intuitive let me borrow some slides so that I could have their data. This is based on Premier database, so it's not really them going around doing this, but it's based on Premier database. And if you look here, this is I'm just going to use the mouse because I think it will work better. So this is the study period, 2010 to 2012, where we went from 3% to 9%. If we look at the VATS adoption rate in that period, we go from 39% to, about 39%. So we didn't move a whole lot. They're like, well, that's because we were doing well. Well, if you look here, we went from 37% to maybe to 40% over a 7-year period. We haven't really changed. We haven't really adopted it. We haven't done what we thought we were going to do with robotics. And so I submit to you that we're probably not going to get there. If you look at the decrease in thoracotomy rate, it's not because VATS is going up. So if we think that we're going to get it all by doing VATS, we're probably not going to make it. And so this is a slide that I shared with David a couple years ago, but this is where, when I went into doing this, I said, I don't need the robot to help me do lobectomies, because we do it great. We're already doing it. And so if you look here, when we started doing ours, we were doing about 60%, and I don't know what happened here, but when we started doing robotic lobectomies, this was when I started, and this is when my partner bought in and started. We went from doing, our high 60 to 80% during our learning curve, and now we're roughly 90% or more. So I think that if you critically look back at yours, you'll find you'll have a similar data. So we're going to improve patient outcomes, we're going to improve the profit margin, because we're going to increase the rate of adoption of minimally invasive lobectomy by using robotics. So how do you get started? How do I plan for it safely, and what steps do I need? Well, it's very different depending on your type of practice and what's happening when you're doing it. If you're a new user in an established service line, your needs are a whole lot less than if you're a new user in a new service line on that robot, or if you're a new user in the hospital that's new to the robot, you have different needs that you'll need to do. With the new user in an established service line, like my partner was, needs less help from Intuitive. A new user in a hospital that's never had a robot before is going to need a whole lot more. Now, fortunately, Da Vinci has a training pathway to help you with this. One of the studies I read talked about the FDA having requirements of some of the training that you need to do, and it's all put into their training pathways, and they will tailor it to your needs. The way we did it at our institution is that we already had a robot in place that was a new user on a new service line. And we said, we're going to go all in on this. We can't just do the 5 or 10 cases that we think it makes sense to do on the robot. We're going to do everything we have on the robot and learn how to use it, and then we'll pull stuff off. And what we also did is we said, well, we have 2 surgeons, myself and my partner who's a little older. We said, we're going to stagger our training. We're going to put every case into my bucket, his case, my case, so that I can get very good at it quickly. And then what we'll do is we'll then transition and he'll do it. So we put him at the bedside. I did the cases for the first 40 cases, and then he did the next 40 cases. And you'll see a difference in sort of how our first 20 cases went. So my first 20 cases, so I did my first case in June, and my first 20 cases, you can see here, I did 5 lobectomies and 2 esophagectomies, so a total of 7 complicated cases. You can say this was more complicated than that, but complicated cases, and 13 straightforward cases. If you look at my partner's first 20 cases, 10 lobectomies, 4 segmentectomies, and an esophagectomy. So 15 more complicated cases and 5 simple cases. It's not because he's a way better surgeon, although he might be, we don't know that, but I'm just saying, it's that we went about a pathway that helped him have much more success early on, because we put him at the bedside. He learned a lot of stuff that I didn't know that what I was struggling with. He could see, he could say, hey, you're struggling with this, so that when he went to the console, I now was at the bedside and can be, okay, good, this is how come we're struggling, and we were able to get him through those cases a lot easier. So it was a very good way for us. I'm not saying it works for everyone, but so also getting started, there's going to be a very different, depending on if you're going straight from open to robotics or from VATS to robotics. I think the transition is easier going to robotics than going from open to robotics than it is to go open to VATS. And the reason I think that is there's multiple things. You have control of everything. You can move everything. If you use the XI, you can bring the stapler and all these things. But you can do the surgery the exact same way you do it open. If you open the fissure every single time, you can open the fissure every single time. And it keeps you from having to learn different techniques to do an upper lobe versus a lower lobe. Makes it less complex. I do think the transition is easier if you're already a very skilled thoracoscopic or laparoscopic surgeon. Just getting ready for this. They're already sort of, the thoracoscopic surgeons feel like they're at the bedside, and that's their, hey, I don't have to move away, I'm at the bedside, but they've already sort of left it. They're not looking at the patient anymore, they're looking at the TV. That's where they're paying attention, they're feeling whatever, but they're paying attention to the TV. And so they've already somewhat moved away, and they really can't palpate, even though. All right, there we go. So, I don't know why it's doing this, but anyway, so when I looked at getting ready for this, as far as how do we know our learning curve and things of this nature, I looked to other societies to try to give us some information to say that this is really an applicable thing, not just in thoracics. But so looking at kidney transplant and robotic kidney transplants, there was a study by Sood et al., and they looked at 3 different groups: people who had kidney transplant experience and robotics, people who had minimal kidney transplant but had experience in robotics, and people who had experience in open kidney transplants but not in robotics. And they found that really the only people that had a significant problem with learning curve were those people who went from open to doing the robotic procedure. And their learning curve for them was about 9 to 12 cases. So there are multiple learning curves when you're looking at this, and we've heard some of it already. We've heard from the nursing staff, the anesthesia team, and the surgeon has one as well. And this is where you've already heard it, but communication is key for this. We looked at our learning curve in a study back in 2014. It was about 20 cases for lobectomies. And you say, okay, cool, well, I now know what I need to know. But in reality, when I try to explain learning curve, it is not a single point that you learn and then you're good. Right? It is a continuum of learning. You learn how to do it, you get kind of good, you have some success, and you're like, okay, good, I'm going to start doing more. And so it's a continual, gradual thing. And I'm still probably somewhere on this learning curve, even though I've done a good number of cases. So, not done. So again, communication. You're going to communicate it with your bedside team. There's going to be a learning curve of how you're going to tell them what to do. Depending if you're on the XI or the SI, you've got to figure out if you're on the SI, who's going to fire that stapler, because you're not going to be at the bedside to fire that stapler. You're going to have to teach them how to do it. Who's going to be bringing things in, that dental roll that you saw earlier, who's going to bring that into? How are they going to do it? Are they going to stab things when they come in? All that part is part of your learning curve. If you spend time early on teaching them, it helps you later on. So. Same thing with Gabe from his talk. So the last piece, and I'm not going to get too much into it because I know Dr. Abbas is coming next, but you need to aggressively go out and show people what's good. So I go to M&M, general surgery M&M, and I don't have to worry about them presenting my robotic thoracic surgery on there because we have our own separate M&M, but I go to general surgery M&M, and the general surgeons who do robotics get up there and they get crushed every single time. The only thing that we ever hear about robotics general surgery is all the bad stuff. So find a way to highlight some of your actual good stuff, because otherwise they'll only focus on the bad. And then aggressively go out and show your data. When you go to tumor board and you're talking about a complex case and you're like, hey, you know what, I think I can do that robotically, and then you do it robotically, come back and give a little, hey, this is what we did and this is how we were able to get this person out of the hospital in 2 days with this superior sulcus tumor instead of having to do a big thoracotomy. So think about those kind of ways to help show people, yeah, this doesn't suck as bad as you say it does. So, all right, that's all I have.
All right, and the last speaker for this session is Abbas. Abbas is well known to all of you here. I'm sure he's one of the pioneers in this field. He's a professor of surgery at Temple, Fox Chase Cancer Center in Temple University, and has really got some great data about the value part of doing robotic surgery. So which one is it now? There we go. The financial impact, what everybody's interested in. Okay, perfect. Thank you.
Thank you, David. We actually, I'd like to announce we changed the name to Fox Chase Cancer Center, and so it'll be the 5M next year.
You're welcome.
Thank you. No, it's a pleasure. What a great meeting. Thank you so much. It's great to see Houston so soon after the happy and the sad, and you guys are great, so thank you for the invitation. These are my disclosures. Just like to, this isn't an exciting talk, and it's really not about technical aspects. It's more about what we're providing. We are all small parts of a big wheel. Our wheel is not quite as big as your little city you have here, MD Anderson, but it's an example of an academic center. There are many of these in the country. Ours, the health system, has actually 4 hospitals. One of them is Temple University Hospital, which you see on this slide. We also have Fox Chase and Jeans and another hospital. And altogether, we have close to 1,000 beds. We have many admissions annually, and we have a budget of about $2 billion. We do about 15,000 surgeries a year, roughly 60% inpatient and 40% outpatient. So what does that mean? Well, when you also look at other factors, technology, things that are coming in, and Dr. Bolton shared this just now, is the adoption rate for robotics seems to really be on the rise. There's probably many reasons for that, and we can discuss later, but currently, at some estimates, about 18% of lobectomies, this is data from the company, may be done robotically. But so we get this data, and we come to our CEOs and we say, you know, this robotics business sounds good. I really want to do it. I think it'll help our patients, help us, and help our bottom line. Well, then the CEO's job is to vet this technology through his or her teams, and then decide on prioritizing. Well, okay, I have many other people who want new toys. Where do I spend it? Where does it factor in what we're trying to achieve, what our mission is? Well, they look at cost of care. And, you know, most of us think of cost of care, we immediately think of, well, what's the capital? How much am I going to spend to accrue this technology, for example? Or what about instruments that we have to keep, disposables, OR time? Those are kind of easy to comprehend, but underneath the surface, as everything else that goes into having a successful program and hospital, salaries, administrative overhead, other instruments. You can't just have an OR with just a robot and robotic instruments. No, it needs everything else that goes into being a normal operating room. And then the length of stay, conversion rate, complications, you know, patients who have complications cost more, readmissions, etc. Also, when you're looking at revenue, you know, we tend to think of, well, you know, how much did I bill and how much did I recover? And what did that impact our contribution margin and net margin? But there's also the other upsides of having a successful program, successful new technology. What about the marketing effect? Am I going to see new patients come in, or new customers, unfortunately, is the word sometimes used? Will it be used as a competitive tool for the hospital across the street? Literally here. Educational tool, research tool. And those are things that maybe academic centers have to look at a little more carefully too. We can't just be seen as the clinical machine, and there's really more to our mission than just pure numbers. And like Dr. Bolton said, you know, there have been some papers that have looked into cost. You know, unfortunately, these papers are written by doctors, and we don't really have a strong understanding of the finances that go into the big machine. Scott Swanson's paper looked at the Premier Hospital database, a large database, and looked at 2 years, about 15,500 patients. And really, the conclusion was, robotics cost more than VATS by about $4,500, and that operating times were greater for non-robotic cases, but length of stay was different, and adverse events were different. So that was an example of a database study. An example of an institution-based study was the one from Swedish, Louis and his group. They just looked at their patients who had lobectomies, either open, VATS, or robotic. They're lucky they have a group with surgeons who prefer to do it in each way, including open, which is nice. They can compare their data. And they found that, no surprise, comorbidities and complication rates were similar, but there was no statistically significant difference in cost when you looked at VATS and open, or open and robotic. However, robotics cost about $3,100. Well, what those two studies had in common is they looked at one thing, the direct cost. They simply calculated length of time in the OR, instrument cost, depreciation, upfront cost, etc. So before I go on, what does it cost? What are those direct costs that we look at and are sort of easier to understand? What's the bare bones if you're going to have a robotic program? You need this, and that'll set you back a little bit. And that's the first thing your CEO will tell you. Oh my God, you know, don't show me those 7 figures. You might want a maintenance plan. I recommend you do get one. instruments. Each time you click it in, it's about $200, depending on your contract. There's nicer new instruments. There's the robotic stapling, the vessel sealer. I love that vessel sealer. It's my go-to. Well, what is it without all the bells and whistles? Well, you can also get the simulator. And certainly, if you have one, it's very useful for the training and actually for the surgeons. They've come a long way. I insist on this. I insist on having a double console. We're lucky. We have 6 robots in the system, and I'm the one who says, don't put me in a room unless I have 2 consoles there, because I can't really teach my fellow or resident anything if he or she are just sitting at the console and I'm not there, or vice versa. And as you know, when you have a double console, it's like driver's ed. You can give, take. And so what I usually start with, and I actually have 3 of our fellows here to this meeting today, is they observe, and as you know, the view from the console is very different from the view from the bedside, and then they gradually get to use 1 instrument and 2, and hopefully by the end they're directing the whole case. There's the Firefly, which will also set you back some, and there's the table motion, right? Which will all, it seems like, every day we're hearing about new things. This is the table. So really, lots of big figures. So when I set out to do this study, really, and my partner and CEO, Dr. Kaiser, has a strong interest in the finances of this, it was really to get me to understand a little more of how this works. So a few terms. Direct costs. Well, those are obviously the direct patient care costs. They're easy to understand, and they're usually the ones that you can easily calculate if you ask your administrators for them. Whether it's the robot, the disposables, the depreciation, number of hours worked by OR staff, etc. But there's the indirect cost, the overhead. And I guarantee that's not an easy number to get. If you go to your administrators and ask them, hey, what was my overhead? They'll say, oh, we don't know. We can, they'll, give you every obstacle possible, so you don't know exactly what their overhead it tends to be a deeply guarded secret, because it tells you how efficient your healthcare system is, how financially efficient it is. Then there's the bottom line. And we'll usually maybe understand our contribution margin, which is total revenue, how much they got, and how much we spent in everything except the indirect cost, which is easy. However, if you want to really get the bottom line, I want to know how Temple Health System did, thanks to me, at the end of the year. That's very difficult. And that's the net margin. So, again, Dr. Kaiser had published on this 15 years ago about the impact of different specialties in surgery, how much we contribute. There's no question that surgery is the driver for hospital finances, but not all services are equal in how much they contribute. And this was a study at the University of Pennsylvania, published in 2005, that found that indeed thoracic surgery had the biggest contribution to hospital margin, and some surgical services even had a negative contribution. Does that mean you should do away with plastics? No, obviously you need the whole service line in order to provide a profit for the whole hospital. So you need them, but not all specialties are created equal, and that was the title of their talk. So why learn about this for our specialty? Well, you'd be hard-pressed to find an independent thoracic surgeon now. Even in private practice, we usually belong to a hospital group, and it's essential, if we're part of that group, to really know how much we're contributing. we have to learn how to share financial data with our hospitals, and this will really be good for both us to understand how much we're doing. Maybe we have an overinflated sense of what we're doing, and maybe they need to also understand how much we're contributing, because I bet you that at the end of the day, the CEO thinks of us all specialties as just the surgeons, and they're always asking, but we need to kind of really let them understand how much we are providing, especially thoracic surgery. So the objective of our study was to look at our financial impact of what having a multi-specialty robotic program in a hospital will do to it, especially if it's an academic, what it does specifically for thoracic surgery, having robotics, and then try to see if we can create a potential cost saving or even loss with robotics. What it is not is I'm not here to compare robotics to non-robotic thoracic surgery or any surgery, or to make a financial comparison. We're just trying to get a better understanding of what the impact is. If you were not doing robotics and decided to go all in and start doing robotics, what that would mean for your institution. So we obtained both IRB and, very important, finance department approval to look at these numbers. We did a retrospective analysis of all patients operated on in 2015, and we included all surgical services that did more than 20 annual cases. We looked at both the robotic and non-robotic, and then we looked at all the data sets that might contribute to this. This is just number of cases done monthly in 2015 by all services robotically. This slide, what this compares is inpatient to outpatient robotics. As you can see, now since then, Medicare did change their outpatient reimbursement a little bit. However, what we found is no matter what service it was, if you did outpatient robotics, you just could not make a profit due to the higher direct cost associated with robotics. However, for inpatients, we were able to see, on average, all specialties about $11,600 in net margin for robotic cases. Now, when you compare robotic to non-robotic, hospital-wise, these are all CPT adjusted, so they're kind of equivalent. We found that the difference in cost between the robotic and the non-robotic was very small. It was about $400. These are all services, not just thoracic, all services comparing robotic to non-robotic. So it wasn't as big once you factor in length of stay and other things as we would have expected. It was about $400 more expensive in general for the hospital to do robotics. This is a busy slide, but worth taking a minute to understand it. It looks at these specialties. Red is number of cases done, yellow is contribution margin, and green is net margin, net income. And as you can see, the numbers don't necessarily, the size of the columns doesn't correlate. The group with the highest contribution margin was cardiovascular surgery, expensive cases. But the service with the highest net income was thoracic surgery. And in fact, urology did the most cases, but unfortunately had a loss, despite them being excellent surgeons, but had a net loss in net income. So we then focused on just thoracic to look to see if we compare robotic and non-robotic cases done in thoracic surgery and saw a difference. Now, these were not CPT matched. In general, we did most lung resections robotically and tended to do sort of the simpler or the decortications, lung biopsies, etc., non-robotically. So take it for what it's worth, but in general, and this is really not strong science, but our robotic cases didn't really cost more than our average non-robotic case on thoracic surgery. Again, these were not matched. But we did want to look at, to see, well, how much are we saving by doing our cases the way we're doing them in thoracic surgery. And we looked back, and there's actually some publications that will give you an estimate of a dollar amount for each of these parameters. So if you save a length of stay of 1 day, that will save you about $1,500. If you save an ICU day, that's about $4,700. Conversion to open, there you go. Transfusions, etc. Complications, you can factor in how much they cost. And OR time per minute is about $11. And then we compared our data. Well, that's fine. Let's compare our data to the STS database, which is mostly VATS and open, in 2015, and see how we compared. We found our length of stay, compared favorably, conversion rate, etc., and we just plotted them in, and then kind of calculated to see, well, compared to VATS, how much would we have saved, and compared to open, how much would we have saved? And we found, potentially, these are potential cost savings, that we may have, we're doing okay, and we may even have a potential cost saving of about $1 to $2 million compared to what you would expect on average to be the cost in the STS database. So in conclusion, robotics is no question an expensive investment for any hospital system. But once it's made, who do you allocate it to, and who, as the administrator of a hospital, who would you expect to drive the margins from robotics? And there's no question, the higher acuity services, the services that have higher CMIs like thoracic and cardiac surgery, will drive higher contribution and net margins from robotics. The lower acuity services, despite high volumes, may not offset the robotic fixed and variable costs because of the new rules with outpatient, with forcing us to bill outpatient separate from inpatient. We just might not be able to recapture the increased cost. And so robotic-related costs may be offset even with the higher investment, if your length of stay is shorter, if your outcomes are better, and get the patients back. With that, thank you.
Thanks, Abbas. Encouraging news, at least. I'd like to invite all of our speakers for the first session. We'll have maybe a 5 to 10 minute question and answer session. Then we're going to take a 10-minute coffee break. Okay. So I'll start off. This is sort of from a nursing perspective. I know that at least at this institution, we always have 2 RNs in the room. Can we have the lights up, please, Leo? There you go. We always have 2 RNs circulating for robotic cases. Do you think that's absolutely required, or could we make that a little leaner?
Is that for me? Question for me?
Either you or Nadine or anybody else.
Generally speaking, Dr. Rice, we would prefer to have 2 nurses for robothoracic procedures. It adds an element of safety that isn't necessary for procedures that are from other service lines.
Mm-hmm.
But comparatively speaking, the nature or the criticality of the procedure requires additional expertise. In many instances, and that's why I'm in full support of having 2 RNs in the room.
David, can we make this more entertaining and challenge that?
Yeah, absolutely. Please. And you guys have in front of everybody, there's a little speaker button. If you could just push that, then we'll be able to hear.
Okay. You usually don't need to hear me because I have a big mouth.
Can you introduce yourself, please?
Yeah, you gotta hold it down as you speak there.
Okay, Robert Surfolio from It Doesn't Matter in New York City. So I'm going to completely challenge that.
Please
I'm going to tell you you're spending way too much money. Absolutely no data for that statement. I can have 2 high school students in there. If they're initiated and if they care and they're properly trained, I can pay them $15,000 a year and get the same outcome. How would you respond to that?
I would challenge that on many levels, in part
All right.
primarily because the level of expertise that's necessary in the event that you needed to do a conversion to an open procedure
I would
or
argue that all conversions can be done without being done urgently. In fact, it's a mistake to convert urgently. It's much better to pack and to wait.
I can't challenge that on a medical level, but from for a physician, but from a nursing perspective, that criticality requires immediate response. And if you have poorly trained or ill-prepared clinicians in the room to facilitate that sort of challenge, it could be very detrimental to the patient.
I loved your talk because you said it's all about teammate engagement. It's not about the number of initials after your name.
That is
which
correct.
drives my cost up through the roof. So I've done 1,700 robotic operations, including 1,100 with just an RN, one, in the room with no mortalities. So I would challenge the fact that we have to be really careful what we tell the audience because they're going to go back and drive our costs up. Nurses are great, but they're very expensive. We can do this with all sorts of people. It comes down to what you said. You said it, and I loved it. It's the one talk I took notes on. No offense, other guys. But it was about teammates and how you engage the teammate, not how many initials they are or what you pay.
I will say that while I would love to have four total people in the room, I never have it. I just have one nurse and one tech in the room. Occasionally we have the orderly who comes in and helps bust out the room at the end. So I guarantee that my turnover times would be way less if I had those 4 people in the room. That's why I love it, but I don't think I'm going to get it.
Along the same line is, do you have a robotic team or do you just use the entire OR pool? We've been doing robotics long enough now that most of all our OR nurses feel comfortable doing robotics. So do you really think we should continue to have a robotic-specific team, or should we just make it a general requirement for all nurses?
At the inception of the program many years ago here at Anderson, we generally had nurses not knowledgeable about robotics at all. So the plan that we put in place was to have every single nurse performing general procedures, be it laparoscopic or open, learn the robotic platform. Once they learn the platform, then that's just another additional tool, not anything spectacular, so there wasn't a need for a specific robotic team. As the procedures became more complex and we had research studies incorporated, it required people with a little bit more expertise, but every single nurse that's working in that area has the ability to do robotic procedures.
We've gone about it a little different in that we have a robotics team, except for thoracic service. So we have every thoracic tech knows how to do robotics, and so we never have any manpower issues on the thoracic service for robotics, but every other service line has manpower issues because people come and go from a dedicated robotics team, whereas on the thoracic team we have plenty of techs and we never have to worry about on the robotic side. So I think I would say get to where we don't have a specialized just robotic team in most places. Again, we don't all have 4 people in the room at most places.
So, Eric Tolosa, Moffitt Cancer Center. Just a follow-up on Mr. Volio's question. So does that mean on your VATS lobectomy cases you don't have 2 RNs in the room? Because I would think that's a higher risk of a conversion to an open procedure.
No, generally speaking, for our thoracic robotic procedures, we have 4 personnel in the room. It's
Right.
other
For
service
VATS
lines.
lobectomy,
Yes.
you have
Yes.
4 people as well.
Yes.
So what does that 4th person do? The equipment?
No, there is an equipment technician that is solely focused on the robot systems and directions from the physician regarding the needs from the exterior of the patient. So the room, circulating the mechanics of the room and any issues that may occur with each of the system components, be it the patient side cart or the consoles, whatever, that individual is solely responsible for that. We did a lot of assessments initially about where the nurse's attention was focused. If you have a single nurse in the room performing the procedures, their attention is not necessarily focused on the patient's care and the hemodynamics related to that. It's focused on the mechanical aspect of the robotic procedure. So we added the element of the equipment technician to take that technical focus and provide it to another individual who is solely responsible for meeting the physician's needs and the patient's needs from a technical aspect.
Yeah, but to further argue the point, if there's mechanical problems that would require an equipment technician, usually the operation stops. Right? The surgeon is not doing anything. The scrub tech is not doing anything. The bedside assistant is doing anything. You essentially have potentially a surgeon doing the troubleshooting that your equipment tech is doing, in addition to your 2 RNs. So you have 3 people that are moving around the room troubleshooting the problem.
And also, don't you have a maintenance plan, or are you just providing your own
No, we
maintenance and
do.
support?
We
Because
do.
if you do, then you're reproducing. You're already paying for it. Why don't you use the maintenance techs?
Our intuitive maintenance people aren't always available, so I would say.
800 number they are. By phone they are.
Yes, true.
Right, but sometimes in the physical space at the time that the issue is occurring, it isn't as robust a response as we need. And in situations where there is a fault or a mechanical malfunction, the nurse is trying to, in most instances, meet the hemodynamic needs in conjunction with anesthesia requests. So they can't possibly be responsible for multiple aspects at the same time without compromising one or the other.
So let's move on to a different topic. What about access? You know, one of the problems when you're a small volume service, you're trying to get started in robotics, you're not doing as many as Rob is doing. How do you justify having access, and how do you get access to the robot? Maybe each of the maybe Billy and Abbas, you could talk about how you've developed the access at your respective institutions.
You get a new job. I think this is important at every level of your career, whether you're just starting out or you're more senior, is think about what you actually want to do. Obviously, you can't just do robotics as a hobby. I think it's sort of an area where you're either all in or you're not. And if it is important to you and you feel it will provide a benefit to your patients and to your service, then you really have to take it upon yourself, because there is going to be negotiation to be done. I think that's where, yes, you do have to understand what its impact will be. You have to explain that, yes, there might be an upfront investment, but it's not just for thoracic. You need it for urology and for GYN. And it turns out that guess who makes the most money when they use the robot? It probably is not the urologist or the gynecologist. It is the thoracic surgeon. And this is where you should put all your investments to really make sure they have as much access as possible. Because when we do a patient with robotics and we're able to get them out earlier, the hospital is saving a huge amount of money.
With just my personal experience, when we went on to robotics, there was no adequate time given to us, and so we just had to get whatever was available. And ultimately, the chairman of the department came to me and said, hey, I don't think you're ever going to get any block time. I think the only block time they'll give you is Saturday morning. And I said, oh, that's not awesome. But I was young, and I said, okay, sure, whatever. So I did a case on Saturday morning the first time. There was a lot of hubbub. I did another one on the next Saturday morning. And then, lo and behold, I got Monday morning block time. So it worked out pretty well for me. So sometimes you have to be able to take it on the chin a little bit.
They weren't sure you're serious enough.
But what about the concept of open access? We've incorporated open access now for two robots every single day, first come, first served. So we've got 4 robots here. 2 are dedicated for the urologist because their volume is about 10 times what ours is. But every single day now there's 2 open robot slots, and we found that tremendously helpful in terms of getting cases.
First come, first served. So I want to book one for January the 3rd,
Yes.
2018.
Absolutely.
And I got it.
You got it. Absolutely.
The problem
we've also
is that
developed
bariatric services will post them months in advance, and you won't be able to post your lung cancer that you saw.
So that is the benefit of working in a cancer center. But point well taken. Not that we don't have big, larger patients, but
In a university setting, you're going to get hernias, and you got everyone gastric bypass is going to be scheduled.
Yeah.
And my poor guy with lung cancer is dying. So
Yeah.
that may work in your silo, but it's not going to be applicable.
yeah, well, that makes sense.
So what do you do, Dr. Foley?
So we have different turnover times. We have 8 robots, all XIs, and the turnover time is different in each specialty. So with cardiothoracic, you have up to 48 hours because their cases are more urgent. My release time, I should say, is 7 days. For the general surgeons, their release time is 2 weeks. So I think it needs to be based on the patient. Again, it's all about your customer and serving your customer. Your customer changes based on your silo.
So if a general surgeon has robotic block time 2 weeks out and he is not booked, then that gets released and anybody else can...
First within his division.
I see.
And then we're setting up a system now, because this is what I've started doing there at NYU. I'm new, where now it's going to get open to everybody. Everybody is so selfish and based in their silo. They don't want to give their OR time out. We have to change that thinking. We have to represent the university, not our department or division or section. So we want to be respectful of your block time, but surgeons think block time are their kids and that they're there forever. No, bro. You can lose your block time.
So it sounds like you don't have block time here, David. You have open exits.
The open cases do not count towards one's block time. Yes, that is true. So we had to dissociate those two because there were times when there was a robot available, but because I didn't have block time on that particular day, I couldn't use the robot, which made no sense, because the worst thing you want to do as an institution is have a robot sitting there not being used, right? I mean, you want to use that thing, it's like an airplane, you want to use it all the time.
So, Dr. Stroller, one of the other things you may want to implement there, so what we've done is not only do we release that time, but we now have a person whose job it is in scheduling to say, okay, on this day, I'm going to send out an email to all the people who schedule on the robot. These days have been released, and and it actually goes to myself.
Yeah,
as
you
well.
guys love to spend money. So we have the same thing. We don't pay an FTE. It's called a Google Calendar, bro. It's real cheap. Goes out every single day.
She already works in the front desk of the OR.
She's probably not going to go away on
Here's
that one.
something. And in New York City, we're paying her too much.
No, we one-upped you, and we penalize people who don't release it by counting against their utilization.
So do we.
Yeah. So.
Albert.
I work in a more community type of environment, and when I looked at our robot committee on 2 occasions, there's a lot of people that had both institutions had block time but didn't use their block time. I'm very protective of their block time. And what we at both institutions have gone in open scheduling have seen dramatic improvement in people that are building like thoracic and stuff like that to get cases on. So I think it's variable depending on what institution, but I definitely practice in a community type of environment, and the private practice guys do not want to give up their robotic block time, and it's impossible to show them that they only use it 30% of the time. So we went to open scheduling, and guess what? The people that wanted to use it, used it, and people that didn't use it, didn't use it much. And then people are always afraid from administration that they're going to bring their cases to a competing hospital. Didn't really happen, So, I think it depends on, you have to know the situation, really, how much people are utilizing it. But nobody wants to give up their block time in private practice.
Well, we're running a little bit behind. One more question very quickly, and then we'll take a break. Can you just push your button?
Just suggestion that...
You got to keep it down.
Yes, suggestion that just to make it as a division block time. So two partners actually, and 2 young partners, and what we do, if we have the block time, and I have the projectomy, which I'm not doing it robotically, my partner who can use it for like wedges to do robotically, so the robot block time has never been, not utilized in the thoracic division. I'm not sure if you're going to do it in your hospitals.
That's how we do it as well. It's per division, not per person.
All right, well, let's take a 10-minute break. We'll meet back here at 9:30. Thanks again to all the speakers.